Module 1. What is diabetes? In this module, we will review the implications of diabetes in the long-term care setting, including common risk factors and techniques for assessing glycemic control. We will also review the American Diabetes Association treatment recommendations, including a position statement published in 2016 focusing on the management of diabetes in long-term care and skilled nursing facilities. Lastly, we will review recommendations from several national professional associations which advocate against the use of sliding scale insulin, also known as SSI, and discuss more appropriate insulin treatment regimens in this setting. This module will end with 4 self-check questions to reinforce key concepts from the section. Diabetes 101. Diabetes continues to be a growing epidemic in the United States, with devastating physical, emotional, and financial implications to patients as well as an increasing burden on the healthcare system. It is estimated that over 30 million people are living with diabetes in the U.S., which equates to approximately 9.4% of the general population. As age increases, so does the prevalence of diabetes. In adults 65 years of age and older, 25.5% have diabetes, which is approximately 2.5 times the national average. Looking specifically at the patient population in the long-term care setting, the prevalence of diabetes ranges from 25 to 34%, indicating that nearly 1 in 3 beds is occupied by a patient with diabetes. So what is insulin and how does it work? Insulin is a hormone made by the beta cells of the pancreas. In a person without diabetes, when they eat carbohydrates, the pancreas produces insulin, which enables the cells of the body to utilize that glucose for energy or to store it for future use. Think of insulin as a key, which opens up the lock on a cell, allowing glucose to enter to be used for energy. Without insulin, the lock cannot be opened and glucose remains outside of the cell in the bloodstream, which leads to hyperglycemia, also known as high blood sugar, which is associated with diabetes. There are 2 main types of diabetes, type 1 diabetes and type 2 diabetes. In type 1 diabetes, a person's own immune system destroys the beta cells of the pancreas, inhibiting their ability to produce insulin, which leads to hyperglycemia, or high blood sugar. The onset of type 1 diabetes generally occurs in childhood or early teenage years, which is why it was previously known as juvenile diabetes. Although far less common, it can occur later in life as well. Upon diagnosis, patients with type 1 diabetes will require lifelong insulin treatment since their pancreas no longer produces the insulin their body needs. In type 2 diabetes, the body does not utilize the insulin it produces properly, which is known as insulin resistance. Early in the disease spectrum of type 2 diabetes, the beta cells of the pancreas produce extra insulin to overcome the body's resistance to insulin. However, over time, the pancreas is unable to continually produce more insulin to meet the body's increasing needs. This results in rising glucose levels over time, which is why we refer to type 2 diabetes as a progressive disease. The onset of type 2 diabetes generally occurs later in life, primarily in mid to late adulthood. African Americans, Asians, and Pacific Islanders are at higher risk for developing type 2 diabetes. Patients with type 2 diabetes can be treated with diet and lifestyle modifications, oral medications, insulin, and other non-insulin injectable medications. Type 1 diabetes accounts for approximately 5% of diabetes in the U.S., while type 2 diabetes makes up the remaining 95% of patients. It's important to note that type 2 diabetes makes up an overwhelming majority of patients in long-term care facilities which have diabetes. So what are the key risk factors for patients to develop type 1 or type 2 diabetes? As mentioned previously, type 1 usually occurs earlier in life and is associated with a family history of the disease. Conversely, type 2 has several key risk factors including weight gain, inactivity, family history, race, and age. Diabetes affects a variety of organ systems in the body and can cause diabetes-related complications in the eyes, skin, nerves, feet, heart, kidneys, and blood vessels. Common symptoms to watch for include blurred vision, which can indicate diabetic retinopathy, swelling in the feet and legs, fungal infections, tingling or numbness in the hands and feet, including nerve pain, which can indicate diabetic neuropathy, as well as skin colorations, calluses, and ulcers, which can be due to poor circulation. When blood sugar levels rise above 200 milligrams per deciliter, a patient has hyperglycemia. Common signs and symptoms include frequent urination or incontinence, increased thirst, blurred vision, fatigue, and sores or wounds that are not healing. If left untreated, hyperglycemia can lead to severe consequences such as permanent nerve damage, vision loss, kidney failure, stroke, and diabetic ketoacidosis, otherwise known as DKA. Hypoglycemia is defined as a blood glucose level of less than 70 milligrams per deciliter. It can occur from too much medication or from missed or poorly timed meals in regards to when an insulin dose is given. Common signs and symptoms include feeling shaky, confusion, feeling dizzy or fainting, being nervous or anxious, sweating, chills, and clamminess, mood swings or irritability, feeling sleepy, and coordination problems, including falls, which are unfortunately very common in the long-term care setting. For treatment of hypoglycemia, review your facility's protocol or check with the healthcare provider in charge. Let's now review the two main techniques for assessing glycemic control. The first, SMBG, or self-monitoring of blood glucose, is commonly referred to as the finger stick method. It uses a small blood glucose meter to check the plasma glucose after a finger prick with a lancet. It is simple, quick, and easy, and can be done anywhere. This test is commonly done to assess a patient's blood glucose before or after a meal. It can also be used to assess a patient's blood glucose if they are showing signs or symptoms of hypo or hyperglycemia, as you can receive the results quickly. An A1C test is a measure of a patient's average blood glucose over a 3-month period and is primarily used to assess a patient's overall glycemic control. The American Diabetes Association recommends an A1C level of less than 7% for most patients with diabetes. Later in this module, we will go into more detail regarding how treatment goals may need to be adjusted for certain patients in the long-term care setting. Let's take a look at the American Diabetes Association position statement for long-term care and skilled nursing facility residents in more detail. The ADA position statement for managing diabetes in the long-term care and skilled nursing facility setting provides varying treatment goals compared to the general population. It is critical to understand your patient's individual setting and needs, and tailor their treatment goals accordingly. For example, a patient who may be in a skilled nursing facility for short-term rehabilitation should be treated differently than a patient residing in a long-term care environment. A1C is not a good indicator for the skilled nursing patient coming out of the hospital due to recent acute illness, so using the fasting and pre-meal blood glucose values from a fingerstick glucose assessment is the preferred method. For long-term care residents who have limited life expectancy or frequent changes in their health status, an A1C less than 8.5% may be sufficient. We will look at this in more detail on the next slide. When you look at treatment goals by the patient's health status, you can see goals vary from healthy residents with an A1C goal of less than 7.5% to a very complex patient in poor health whose target A1C is less than 8.5%. Overall, as your patient's health worsens or becomes more complicated, A1C goals become more relaxed. Always refer to your facility's protocols. Let's now review the various treatment options available for managing diabetes. Type 2 diabetes is most commonly treated with oral medications as first-line therapy. There are several classes of oral diabetes medications which work through various mechanisms to reduce hyperglycemia or high blood sugar. Some of these oral medications work by increasing insulin secretion in the body, while others work to decrease the insulin resistance. Many oral medications for type 2 diabetes can be used in combination with each other for an increased effect on reducing blood sugar. Since type 2 is a progressive disease, many patients who were once well controlled using oral medications may progress to requiring insulin to manage their blood glucose. The table on the right-hand side of the slide summarizes some of the most common oral medications by drug class, including their brand name, generic name, and common dose range. Nearly 60% of residents living in the long-term care setting use insulin to manage their diabetes. Most patients in an acute care setting are also on insulin. Insulin is recognized as a high-alert medication by the Institute for Safe Medication Practices, or ISMP, since it can cause significant patient harm when used in error. There are 3 types of insulin: basal, bolus, and premixed. Basal includes long-acting or intermediate-acting insulins. Bolus includes rapid-acting and short-acting insulins. And premixed includes a combination of the two. Since insulin cannot be taken orally, it has to be injected or infused into the body. The most common forms of insulin delivery are injecting using either a vial and syringe or a pen and pen needle. A list of insulin types, including their brand names and formulations, are provided in a table to the right-hand side of the slide. This graph represents normal physiologic insulin levels over the course of a day in a person without diabetes. You can see 3 peaks, which represent an increase in insulin levels in response to breakfast, lunch, and dinner. In addition to the 3 peaks, you can also see a baseline increased level of insulin throughout the course of the day, which is referred to as the basal insulin. In a person with diabetes, you will see a blunted peak response for insulin after meals, which means that the body is not producing enough insulin to adequately lower blood sugar after a meal, resulting in hyperglycemia, or high blood sugar. Since patients with diabetes have a blunted insulin response to a meal, or have an increased insulin resistance to the insulin being produced, the goal of insulin therapy is to mimic the effect of insulin in a healthy person without diabetes. Basal analog insulins are intended to cover a patient's insulin needs over the fasting state, such as when a patient is sleeping, while rapid-acting insulin analogs are meant to cover glucose excursions resulting from a meal. Other insulin options include regular human insulin and NPH insulin, shown on this slide, which do not mimic normal physiologic insulin as closely as basal or rapid-acting insulins do. Now let's focus on various approaches to how insulin can be administered. In this section, we will review sliding scale insulin, or SSI, and discuss some of the common challenges of the use of this method. Sliding scale therapy approximates daily insulin requirements. The term sliding scale refers to the progressive increase in pre-meal or nighttime insulin dose based on predefined blood glucose ranges. First and foremost, sliding scale insulin is not recommended by leading diabetes professional associations, including the American Diabetes Association, the American Medical Directors Association, and the American Association of Clinical Endocrinologists. The American Diabetes Association recommends avoiding sliding scale insulin and instead recommends using once-daily basal insulin injection as a reasonable option in older patients. The American Medical Directors Association specifically recommends not using sliding scale insulin in long-term care facilities as it is a reactive way of treating hyperglycemia. The American Association of Clinical Endocrinologists also states that sliding scale regimens are ineffective and potentially harmful when used alone. Despite these strong recommendations against the use of sliding scale insulin, some facilities continue to use this outdated methodology and should consider alternative approaches. As mentioned, sliding scale insulin bases the insulin dose on the blood sugar level just before mealtime. You can see in this chart at the bottom left that insulin is not administered until the blood sugar is already elevated, versus giving the insulin proactively to prevent the blood sugar from spiking in the first place. This is why sliding scale is referred to as a reactive way of controlling blood sugar. The Beers criteria for potentially inappropriate medication use in adults recommends against the sole use of sliding scale for insulin. Reasons to avoid sliding scale insulin include a higher risk of hypoglycemia without improvement in hyperglycemia. A reactive approach can lead to rapid changes in blood glucose levels, resulting in hyperglycemia and hypoglycemia. And it requires significant nursing time and resources compared to other administration methods. In addition, One study showed that the incidence of a hypoglycemic event was over 2.5 times greater in sliding scale patients compared to non-sliding scale patients. Sliding scale insulin is reactive rather than proactive. Sliding scale insulin lacks evidence of efficacy. Single or multiple daily insulin dosing regimens should be considered over sliding scale insulin. The addition of a once-daily basal insulin addresses fasting blood glucose needs and can help lower a patient's A1C. Bolus insulin may be added at mealtimes if needed, or pre-mixed insulin regimens offer yet another alternative. In summary, individuals with diabetes have high levels of blood sugar. It is important to recognize the signs and symptoms of hyperglycemia, or high blood sugar, and hypoglycemia, low blood sugar. Type 2 diabetes is a progressive disease, and many individuals will require insulin over time. Diabetes can cause serious complications if not well managed. And avoid the sole use of sliding scale insulin. Now, let's work through a self-check quiz together to reinforce some of the key learnings from this module. Question 1. Insulin is produced by A, the liver, B, the kidneys, C, the pancreas, or D, the gallbladder? Great job! The answer is C, the pancreas. Question 2. Which of the following is a symptom of hyperglycemia, or high blood sugar? A, frequent urination or incontinence, B, increased thirst, C, blurred vision, or D, all of the above? Nice work! The answer is D, all of the above. Question 3. What may cause hypoglycemia in a patient on insulin? A, too much sugar, B, missed or poorly timed meals, or C, inactivity? Yes, the answer is B, missed or poorly timed meals. Last question, number 4. True or false? There is a higher risk of hypoglycemia without improvement in hyperglycemia management with the use of sliding scale insulin. The answer is true. Congratulations, you've completed Module 1.